She's 48, ejection fraction 20%, already on lisinopril, furosemide, carvedilol, spironolactone, and digoxin. Today, she tells you she's more out of breath. You look down, 2+ pitting edema, crackles on inspiration. She's already on 4 drugs for this. So what do you actually add? The answer separates a good pharmacist from a great one. So let's break it down. Heart failure. Guideline-directed medical therapy across the ejection fraction spectrum. This is one topic where I know the drugs and I know when to use them are 2 completely different skill sets. Everyone can name the 4 pillars: ARNI, beta blocker, MRA, SGLT2 inhibitor. That's not the hard part. The hard part is this isn't a sequence, it's a checklist. You don't have to add them in order. You individualize based on symptoms, vitals, renal function, and whether the patient can even come back for follow-up in 2 weeks. Direct to ARNI is now preferred over starting an ACE inhibitor first when it's feasible. Beta blocker, only 3 are proven here: bisoprolol, carvedilol, metoprolol succinate, not tartrate. Start low, double every 1 to 2 weeks. 3 phenotypes, 3 different rule books. Heart failure reduced ejection fraction 40 or less. This is where all 4 pillars are class 1. Mildly reduced ejection fraction, 41 to 49, same 4 drug classes, just class 2B. Think of it as a reduced ejection fraction light. HFpEF is one people mix up. HGLT2 inhibitors are a real winner here, class 2A, but beta blockers only if there's a compelling reason like AFib or prior MI. Otherwise, they're not recommended, and that trips up most people constantly because we're so trained to reach for a beta blocker in heart failure. Once the 4 pillars are optimized, add-on therapy is about matching the patient in front of you, not memorizing a list. Symptomatic African American patients, New York NYHA 3, class 3 or 4, hydralazine in combination with isosorbide. That's a 43% mortality reduction from a heart failure patient. That is not a small number. Resting heart rate 70 or higher on max beta blocker in sinus rhythm, ivabradine. Recent hospitalizations or rising natriuretic peptides, vericiguat. And digoxin, reasonable for persistent symptoms, but remember, no mortality benefit. It's there only for symptoms and hospitalizations. Just as important as what you add is what you take away. NSAIDs, sodium and water retention, blunts your diuretic. Non-DHP calcium channel blockers if ejection fraction is 40 or below. Verapamil and diazepam are out. Amlodipine and felodipine are fine. Class 1 and 3 antiarrhythmics are dangerous here, except amiodarone and dofetilide. Those 2 are safe. Everything else in that category is proarrhythmic in a failing heart. Andronadarone, contraindicated outright in NYHA class 3 or 4, or after a recent decompensation. Back to the patient case. LF, 48, alcohol-induced cardiomyopathy, ejection fraction 20%, on all 5 drugs including digoxin, and she's decompensating, crackles, edema. So what do? Not increase the beta blocker. She's fluid overloaded right now. That's the wrong moment. Not the lisinopril, she's basically already at target. Not digoxin, her levels already 0.7 and in range. The answer is empagliflozin. It works independent of her volume status and adds mortality and hospitalization benefit she isn't getting anywhere else in her current regimen. Thank you, and stick around for section 2 where I will go over atrial fibrillation. And please don't forget to like, comment, and subscribe.